webinar series. Tonight's topic is the physiology of oxytocin and preliminary plans for the Phase 2 oxytocin trial presented by Dr. Jennifer Miller from the University of Florida. Before we dive into this evening's topic, let's review some housekeeping notes. Please take a moment to write down the dial-in number and access code for tonight's presentation should you become disconnected from the call. The number is 415-655-0051, and the code is 387-342-140. For those of you using the voice IP option, you may choose the option of dialing in at any time during the presentation. There is a question segment planned towards the end of the presentation. Please note that the dialog box located to the right of your screen has an option for you to ask questions throughout the presentation so nothing is forgotten. Your line is muted to alleviate distractions, so if you have any difficulties during the presentation or need assistance, please use this question box throughout and I will be happy to provide assistance as best I can. Please do not use the chat box, but use the question box. If this dialog box is distracting to you, you can click the orange arrow on the upper left to minimize it, and then click the same arrow to open the box back up and enter questions or comments. Our presenter tonight, Dr. Jennifer Miller, needs no introduction to our Prader-Willi community. She's a well-respected and well-loved physician and researcher. And with that, I will now turn the presentation over to her.
Thank you, Julie. I really appreciate this opportunity to talk to you guys about oxytocin and the preliminary plans for a Phase 2 trial that we are starting to try to fundraise for. Next slide, please, Julie. There we go. So what is oxytocin? I figured for those of you who are not endocrinologists, I'd start with the basics and explain what oxytocin is and why we think it's important for Prader-Willi syndrome. Oxytocin is a hormone which is synthesized in two of the nuclei of the hypothalamus, the paraventricular and supraoptic nuclei. The receptors are found widely throughout the central and peripheral nervous system. They're also found in the heart, the gut, the kidney, and the brain. Oxytocin mediates social behaviors by increasing trust and facilitates a more positive physiologic and psychologic response to stressful stimuli. Autopsy studies done by Dick Schwab in the 1980s and early 90s showed a deficit in oxytocin-producing neurons in the brains of people with Prader-Willi syndrome. Next slide. So there are two hormones that are important when we're talking about oxytocin. Oxytocin is one of them, and the other one is kind of a sister hormone to it called arginine vasopressin, or AVP. They're related neuropeptides. They're both produced in the same nuclei of the hypothalamus, and dysregulation of both of these neuropeptides has been associated with changes in behavior and especially issues with social interaction. The problem is that these two hormones are very, very similar. They're located in the same area of the brain, but they play contrasting roles in relation to social and adaptive functioning. So the arginine vasopressin actually plays a role in increasing arousal and defensive behaviors. So what it does is it creates anxiety, it creates temper tantrums, it creates anger. Whereas oxytocin actually is associated with positive social interaction, as I mentioned before, with reduced anxiety and with lower levels of reacting to stressful stimuli. Next slide. So both oxytocin and arginine vasopressin have specific receptors, but the fact that they're so close evolutionarily, they're located on the same chromosome, like I said, they're in the same area of the hypothalamus, there's crosstalk between them and interaction of the molecular systems. Given the fact that both of these neuropeptides affect social and repetitive behaviors, modulation of these two pathways is being experienced in a number of neurobehavioral disorders, including things like autism, schizophrenia, Fragile X syndrome, and Prader-Willi syndrome. At high levels, oxytocin and, I'm sorry, my other line is beeping, I apologize. At high levels, oxytocin and arginine vasopressin can be partial agonists to the other receptor. So what that means is if you give a high dose of oxytocin, it can actually bind to the AVP receptors, the arginine vasopressin receptors, and create those behaviors that arginine vasopressin is typically associated with. So a high dose of oxytocin could cause problems with increased anxiety, increased temper tantrums. And the same is true for arginine vasopressin. If you gave a high dose of that, it could actually crosstalk with the oxytocin receptors and create some positive effects, even though typically it has negative effects on how you perceive social stimuli. Next slide. So I wanted to go into what we've learned from mouse models before we talk about what we've learned from the human studies that have been done on oxytocin. So there's been several mouse models studied for oxytocin. The first one was mice that are deficient in the oxytocin receptor. These mice are like the humans with Prader-Willi syndrome in that they have a decreased amount of oxytocin receptors present in their brain. These mice have decreased cognitive flexibility and a resistance to change of a learned pattern of behavior, much like we see in kids and adults with Prader-Willi syndrome. The MAGEL2 knockout mouse, which is a model for Prader-Willi syndrome, also has significantly reduced numbers of oxytocin receptors in the brain. And the oxytocin receptors that are deficient in this particular mouse model are located specifically in a region that's associated with fear and anxiety response. So these MAGEL2 deficient mice have a decreased interest in making new relationships, exploring new partners, exploring new objects. They really are very rigid and fixed in their way. They don't want to explore anything new. In addition, they have altered spatial learning. So they have difficulty with mazes and figuring things out visual spatially. Next slide. Julie.
I am. It's not advancing. Give me a minute. Having a night tonight, aren't we?
We are.
There you go.
There you go. All right. So the MAGEL2 knockout mouse, the model mouse that we often use for Prader-Willi syndrome, demonstrates a 50% neonatal lethality due to deficits with sucking and swallowing and failure to thrive. So a few years ago, Francois Muscatelli, who's a researcher in France who works with these mice, found that giving an injection of oxytocin very early in life can rescue the survival, and they actually got a 100% survival rate as opposed to a 50% lethality rate. So this was really exciting and suggested that perhaps giving oxytocin to babies with Prader-Willi syndrome might potentially do the same thing, improve their sucking and swallowing, and improve their failure to thrive. Christian Schaaf's group at Baylor in Houston subsequently showed that giving oxytocin daily from birth to day 7 of life prevented all of the problems that we saw in the MAGEL2 knockout mouse that I mentioned before. So they now were willing to explore new objects, to find new partners, and it fixed the spatial learning deficits in these mice. So again, very exciting, suggesting that perhaps early treatment with oxytocin could be very beneficial in the long run for individuals with Prader-Willi syndrome. So these findings, like I said, suggest that at least some of the cognitive and behavioral phenotype that we see in Prader-Willi syndrome can be potentially rescued postnatally. In addition, the group from Baylor rescued the behavioral social recognition deficits in the adult mice. Just giving 1 dose of oxytocin, they saw improved social behaviors in the adult mice, which is also, again, very exciting, suggesting that we can use this drug to treat individuals well after birth with Prader-Willi syndrome and see benefits. Next slide. So in summary, both the social deficits and the behavioral rigidity improved with oxytocin administration in both of the mouse models that were deficient in oxytocin receptors. These findings suggest that oxytocin could be beneficial for individuals with Prader-Willi syndrome who have both a deficiency of oxytocin receptors in their hypothalamus as well as a deficiency of MAGEL2 function, which is found on chromosome 15. Next slide. So in humans, intranasal oxytocin has been studied, I would say, relatively frequently. It's a very exciting hormone recently because of the issues that I mentioned in the mouse model. And so they've given oxytocin to healthy human individuals, and they found that it improved prosocial behaviors and improved trust. It also increases gaze toward the eye region of the face, which has been associated with improved facial memory. They found that people who were given intranasal oxytocin, and again, these are just regular healthy humans, had better recognition of social cues that they were receiving from other people and improved performance on a test called Reading the Mind in the Eyes test. That's a test where they show people different expressions just showing the eyes on the face. And you have to tell what they're feeling just by looking at their eyes. Are they angry? Are they sad? Are they happy? And the oxytocin improved that performance. It also has been found to have what's called anxiolytic effects. So it decreases anxiety, it improves social interactions, it reduces fear, and as I said before, it improves the ability of healthy volunteers to interpret very subtle social cues by just looking at the eyes. Next slide. So Mate Taubert did a study a couple of years ago where she gave a single dose of intranasal oxytocin to adults with Prader-Willi syndrome. And she found that one single dose showed improvement in social responsiveness and possible improvement in appetite in these adults. This is similar to what Dr. Schaff saw in the MAGEL2 mice with just giving a single dose of oxytocin. Up to 2 days later, they still had increased trust in others, less sadness, and less disruptive behavior. However, then last year a study came out from Stuart Einfeld's group in Australia where they used a much higher dose. They started with 18 international units twice a day for patients ages 13 to 15 and 24 units twice a day for patients 16 and over. Not only did they not see any positive effects, but when they increased the dose, they actually saw negative effects. So they saw worsening behaviors, temper tantrums, and anxiety. The thought is this is because of that crosstalk between the oxytocin and the arginine vasopressin that I mentioned before. So by giving too much oxytocin, that it actually bound to those arginine vasopressor receptors and caused the opposite of what you wanted. So most likely at the lower doses where he was giving them twice a day, you were seeing binding to both oxytocin and arginine vasopressin receptors, which sort of canceled each other out, so you saw no effect. At a higher dose, you then got more binding to the AVP receptors, and you got negative effects. So this is why a study is necessary to do dose finding for individuals with Prader-Willi syndrome, because we can see that without the right dose, you either get no effect or you get negative effects. You want to get the right dose to see the positive effects that Dr. Taubert saw. Next slide. So right now there are several studies ongoing in Prader-Willi syndrome. We are doing the phase 1 study along with Virginia Kimonis at UC Irvine and Merlin Butler at Kansas. It is going on right now. It's not quite finished yet, but we're very excited by the preliminary data. There is a phase 1 study going on in infants with Prader-Willi syndrome in France. Up to 6 months of age, they're giving various doses of oxytocin to see effects on feeding, sucking, and swallowing, social bonding with the parents, and looking at other people's faces. In addition, in the autism world, there are phase 1 and phase 2 trials ongoing to evaluate the safety and efficacy of oxytocin in autism and autism spectrum disorder. These studies, I've been asked the question a lot about autism, and the thing is that these studies on autism have shown very mixed results that have been done previously. So right now they're doing very large dose-finding studies of autism and autism spectrum disorders, hundreds and hundreds of patients, to try to find the right dose, the safest dose, and the most effective dose. Those studies are all being funded by the NIH. We're also doing a trial investigating the use of a melanocortin 4 receptor agonist, which is called RM493, which theoretically should increase endogenous oxytocin production in Prader-Willi syndrome. So that's also an exciting area that we're focusing on as well. Next slide. So why do we need to do more research? If there's research going on right now in Prader-Willi syndrome, there's research in autism. Well, really, there's several things that I feel like need to really be focused on in the next study. We don't know how intranasal oxytocin actually reaches the brain. Does it go up through the nose and cross into the brain that way? Does it get absorbed into the bloodstream of the nose and get absorbed through the blood-brain barrier? We don't know, but we definitely need to know how it gets into the brain, how it regulates the oxytocin receptors, and how it changes the pathways in the brain with different doses or with chronic doses, because the studies that are ongoing are all very limited doses. As I told you, Dr. Tobera's study was 1 dose. Our initial phase 1 study was 1 week of dosing. These are not long enough to see what changes actually happen with chronic dosing of oxytocin. Lab test results measuring oxytocin in the blood have great limitations. They can detect things that are not oxytocin but are closely related to oxytocin, and they measure them as oxytocin, so you may get falsely high levels of what's presumed to be oxytocin in the blood, but it's not really. It's just one of the metabolites that's similar. Different techniques in terms of collecting the blood, how you collect the blood, the preservative you put in the blood, that kind of stuff can affect your results greatly. In addition to those problems, the data from the Einfeld trial is likely due to the fact that it was an overdose effect. So dose-finding studies have to be done in order to find the best safe and effective dose for each individual patient. In addition, functional MRI studies, which are studies we've done in the past looking at appetite in Prader-Willi syndrome, can provide a very nice surrogate endpoint to assess the effects of intranasal oxytocin on neural pathways for both appetite and anxiety. You can look at both of these endpoints using functional MRI, but these haven't been used widely for oxytocin studies in humans. Can you go to the next slide, Julie? So this is just a schematic showing the effect of oxytocin on the brain using functional MRI. This functional MRI is actually just looking at what we call resting state, so the brain at rest. And what you see is there's actually increased activation of various areas of the brain with just a single dose of intranasal oxytocin versus placebo. So this is super cool because it means that oxytocin actually may affect other areas of the brain besides what we are targeting, which is anxiety and, of course, food-related behaviors. And it may affect them in a very positive way because there's increased brain activation. Next slide. So, and the main reason to me, I mean, it's very personal to me because I think that the anecdotal data from parents who I've seen whose children have been treated with intranasal oxytocin, the parents who are in Europe and have been able to obtain it through physician prescription, that data is just stunning to me. I'm going to show you several quotes from parents, and I apologize for reading them when you can read them yourself, but I just think they're really telling as to the effects of this drug. So this parent, this was after 6 months after her child had been on intranasal oxytocin. She's become more talkative and animated. As far as her appetite and food seeking goes, she really doesn't food seek at all anymore. I haven't had to move the trash can into the garage in several weeks. She hasn't tried to get into cabinets or the refrigerator, even if we leave them unlocked. She rarely asks me for her snacks or meals. She definitely eats everything when we serve it to her, but the anxiety she used to exhibit is virtually gone. Now, that child is on a dose of 16 IUs once every 3 days. Okay, so not every day, not twice a day, once every 3 days. Next slide. Another parent whose child has been on oxytocin for 1.5 years said, our child is currently 4.5 years of age. He started going into phase 2A at age 3. We knew there was no medication to stop this syndrome, and we knew the future of our child. So we started oxytocin nasal spray. Rapidly, we saw improvement of his motor skills, impact on his appetite. Now he says, I'm not hungry, I'm full. I think he has a normal appetite. His teacher says, I don't know, but it's like something has changed. His dose right now at 4.5 years of age is 8 international units once every 4 days. Next slide. I put the dosing on there so you could see how variable it is, number one, and number two, how we have to be so careful with dosing. And this is why we tell parents, please do not buy it over the internet. Please do not have your physician try to prescribe this for you. We need to have the right dose so that we can avoid any side effects and get these benefits in the kid. This child has been on oxytocin for 2 years, and the mom said, what if I could tell you that your child could be changed even though he has Prader-Willi syndrome? What if he was more present, more engaging, participated in class, no longer wanted to play alone, and actually cared if you didn't feel well or asked how you are? That's what oxytocin has done for my child. And his dose is 16 IUs once every 3 days. And the last one? The last quote, the child has been on oxytocin for a year. I asked both the child and their parents, and this is what the child said: I'm not as hungry anymore. Mom said he doesn't think about food as much anymore. He's no longer stealing food. He's doing much better cognitively. He and we love this stuff. Parent number two, the dad, said compared to before, he overall really seems to look for and ask about food less often. And his dose is 16 IUs once every 3 days. Next slide. In addition to those experiences, which I personally have found stunning, as I said, we've been doing this phase 1 trial, and what we've seen anecdotally, we're still blinded, so we, theoretically do not know what week children were on drug and what week they were on placebo, although in most of the kids, parents felt they could tell. And the things that they saw were decreased anxiety, decreased question asking, less obsession with time is related to food. So many of you who have kids in phase 2B know that they're like, what time is it? 12 o'clock is lunchtime. It's 12 o'clock, it's lunchtime. They didn't worry about that. The time went by and they didn't ask about it. They weren't worried about food. They were tolerating others eating around them without asking for anything. They were waiting very patiently for their meals and snacks. And interestingly, they had a decrease or stoppage of skin picking in some, which may be related to that decreased anxiety that we expect that oxytocin will help with. Next slide. So all these things together has been what's made me want to get this next trial up and running. I'm super excited by the anecdotal data. I'm super excited by our initial preliminary phase 1 anecdotal data. And I just feel like given the potential this medicine has to help in this syndrome, there just shouldn't be any reason to wait. We really need to get this medicine to our kids. I think it could be life-changing. And so I think that the potential to decrease some of the core symptoms that these children have is just remarkable. I want to make life easier for our kids, and I believe this drug, when it's dosed correctly, has the potential to do that. Next slide. So the proposed study design for phase 2, and this is still preliminary because we don't know yet about phase 2. It will depend on the funding. But the plan is to do a double-blind, randomized, placebo-controlled trial. Hang on, I'm sorry, my computer did something funny. So with a crossover design, so that everybody in the trial would get both drug and placebo. We did this in the first trial as well, and I like it because each child is their own control. Now, in the infants, I don't think it's fair to placebo control. So we are going to try to do a study where we replicate Dr. Taubert's findings and do 10 to 15 infants, giving them a dose of intranasal oxytocin to evaluate the effects of 1 week of dosing on their sucking, swallowing, feeding, functional MRI findings, and do we change the way their brain is responding to stimuli, and their social interaction skills. So how they look at their parents, how they bond to their parents, how they look at others. And then my hope is to have about 50 children who are in nutritional phase 2B or 3. So these are the phases where there's increased anxiety about food, increased appetite, increased anxiety about things in general, to evaluate the effect of different doses of oxytocin on eating behavior, anxiety, social skills, and functional MRI. Next slide. The study design will obviously depend on the funding. So, people have asked me, why don't we have a protocol that they can look at? And we don't have a protocol because the protocol honestly will depend on the funding that we have, the number of kids we can enroll, the number of sites throughout the United States and other countries that we can include, and the number of outcome measures that we can test all depend on how much funding we have for the study. So we can't design the study without knowing what we have available. Next slide. So a lot of people have asked me a lot of questions about this. Why are we raising money for this trial? Why isn't Big Pharma paying for it? Well, the answer, quite honestly, is I have no idea why they're not interested in this drug. I have a suspicion. It was pulled from the market in the United States many years ago because it was not a moneymaker for the company that manufactured it. And the studies in autism have been so varied and all over the place that I think that they don't want to invest the money that it would take to run these trials without knowing in advance that there was real potential for positive benefit. And I can talk till I'm blue in the face, but what they've all told me is, show us the data. Show us that it works, then we'll talk. So I feel like we've got to run this phase 2 to get them interested, to make them want to do a phase 3 trial and get this on the market for our kids. We could go through the NIH. I've talked to the NIH a lot. They're very excited about the oxytocin drug. We even had an oxytocin meeting in April at the NIH. And so we could go through them, of course, but it can take up to a year or more for funding. And funding is very difficult to get from the NIH. So you're not guaranteed that you're going to get it. Even if they really like your proposal, you know, it's competition with other grants. They may like other grants better that have nothing to do with Prader-Willi or oxytocin. And then another question I've been asked is, why not partner with the autism researchers? You know, they have money to do it. Well, they have money for their own studies, and that's all they have money for. Again, they're doing hundreds and hundreds of kids, and they've gotten very large grants to do it, but it takes very large grants and a huge amount of money to do randomized placebo-controlled trials. So all the money that they have is being used for their own trials to try to figure out if it's truly effective in autism, and if so, is it effective in just a certain subset or in everybody with autism. Next slide. So the other thing that people are worried about is that the drug's not commercially available. So what happens if the trial finishes, the phase 2 trial finishes, and they're not able to get drug right away? Well, this is true for any phase 3 trial, or phase 2 trial, I mean. Every phase 2 trial we've ever done, the drug is not commercially available when we're doing the study. So it's never going to be that you're going to do a phase 2 trial and immediately get drug. There has to be a definitive phase 3 trial, which costs millions and millions and millions of dollars. It's got to be paid for by a drug company. We couldn't raise that kind of money. So we're working for this study to get Big Pharma interested in this medication for use in Prader-Willi syndrome. So that they will then fund the phase 3, and then we can get the drug approved by the FDA and available for our kids as soon as possible. Again, we could wait. We could wait and get, you know, and I could continue to talk and try to get people interested. I could wait and apply to the NIH, but I don't want to. I've seen these results. I've talked to these parents. It's remarkable. I want to get this drug out as soon as we can. Next slide. So the Prader-Willi Syndrome Association of the USA and TREND, which was started by Maria Picone and her husband, have partnered to help us raise these funds for this phase 2 trial with your donations. The site for the donations is there. It's the only site where you can definitively target your donations to go directly to this study so that we can get the study up and running as soon as possible. And I think that should be it. Next slide. Is that it? Mm-hmm. That's what I thought. Okay, questions?
Well, let's start to tackle some questions. And I will remind our attendees that Dr. Miller cannot answer any questions about phase 1 results as it's still ongoing. So let's see what we have that you've not addressed already. You've addressed how to participate in it. That was one parent's question. So there will be some notifications.
Julie, I'm going to interrupt you for 1 second. I will say that Dr. Driscoll and I have talked a lot about this, and the first study we did put an age limit on. We did 5 to 11-year-olds. For the second study, we're hoping to just go with nutritional phase. So rather than age, it will just depend on the child's nutritional phase. So if they're in phase 2B or 3 at 2 years old, they could be in the study, or at 3 years old, they could be in the study. So that's our hope. We still have to, of course, approach the FDA and make sure they're okay with that, but with the safety results that we've seen in the phase 1 study and in other studies that have been done, we feel pretty confident that they'll be okay with that. So it's not going to be age-related.
Okay.
Sorry, go ahead.
No, fine. If oxytocin gets approved as a treatment for our kids, do you know at what age they will start it?
No idea. I think that will depend on the results of this study and probably a phase 3 study as well. So, we're going to be looking at, what effects it has in infants, what effect it has in young children, in adults, in every age group to try to see. I suspect it will likely be, and this is just a proposition, I have no idea, but I suspect it will be like growth hormone, that when it first gets approved, everybody will get to, get on it at whatever age they are, with whatever dose they need, and then we'll start, over time, deciding what ages to actually put kids on. So, when growth hormone was first approved in 2000, everybody went on at age 2 and up, and then we started doing the research to look at the infants, and now infants are starting it. So I think it will just be, time dependent and study dependent on what we find.
Okay. Are there other side effects of oxytocin?
So the side effects are really minor. There is a potential for low sodium levels because it does have receptors in the kidney and could hit those receptors in the kidney, causing you to pee out extra salt. We monitored this very carefully, and we're going to monitor it carefully during a phase 2 as well. But so far, we haven't seen any sign of that, not even a hint. And the other thing is you could potentially get some swelling of the legs, but we, again, did not see any sign of that at all. It's a pretty safe drug.
Is AVP,
as long as you dose it right.
I'm sorry?
I said as long as you dose it right.
Okay. Is AVP at all related to the amino acid L-arginine? If so, can taking supplemental L-lysine offset any overproduction of AVP?
Excellent question, and the answer is it's not known. No one knows what will cause a reduction in overproduction of AVP. So they are related, and there's been some thought of that. There's also some drug companies that are trying to develop AVP receptor antagonists to block the AVP receptor so you wouldn't get those side effects. But right now there's nothing that's been studied that works to change that side effect if you overdose.
This may be a premature question, but how does one get their child into the phase 2 trial?
So I think that once we have the money to do the phase 2 trial, we will put out an announcement, and we'll start screening people. And just like we did for the phase 1 trial, we'll have you call. We'll do a pre-screening over the phone to make sure your child qualifies in terms of nutritional phase and all that kind of stuff. And then the first, however many we can put in the study will qualify.
Very good. The next couple questions were along that same line. Is the Foundation for PWS also interested in funding this research?
They are interested as well, and so they want to see the protocol first. So, again, that protocol will depend on how much money we can actually raise to start with to decide what we're going to be able to do.
Are there any potential, quote, big donors or sponsors to fund the trials? Aside from our little fundraisers, what else can we do to help? Can we pester Big Pharma? I don't have money or wealthy friends, but I can be a squeaky wheel.
So the answer is I don't know. I don't know of any big potential fundraisers. If I did, I probably would have already approached them. No, I definitely would have already approached them. I don't think bothering Big Pharma is going to do any good at all. Both Dr. Tobert and myself have bothered Big Pharma nonstop for the past 3 years and have gotten nowhere. Again, I think we just have to show them the data to get them interested. So I think even small fundraisers, any small amount, I think to get us to what we need to get, to get the study done is extremely helpful.
How long do you think it will take until we can get the medication?
I'm hopeful within 3 to 5 years. I hope it may be shorter than that, it may be longer than that, I don't know, but I'm really hopeful that we can move it fast if we can get this study done, and show the data to people who are interested, the pharma companies.
Is oxytocin compatible with Omnitrope?
Yes, it doesn't have any side effects with growth hormone. All the kids that were on the phase 1 study were on growth hormone, and it had no problems.
My son is taking Seroquel and Cipralex daily. Will he have to stop taking it when taking oxytocin? He is 24.
So the answer is we did not stop any of the psychiatric medicines. There's no evidence that it interferes with any of the psychiatric medicines. You may be able to stop them if things get better with the oxytocin, but you would not have to stop them for a study. We ask that medications remain stable for any study that we do.
Who will provide the oxytocin for your phase 2 study?
It's a very good question, and right now it will probably be the Novartis preparation, although we are working, some of this money may be used to hire what's called a contract manufacturer to make the oxytocin for this phase 2 trial that can then be bought by a company to do the phase 3 trial. We're not sure yet. We're still working on that part of it, and again, that all depends on funding.
Why is FPWR not helping fund this study?
They are interested in funding the study. Again, they just want to see a protocol first, and we just don't have a protocol because we can't make a protocol until we know how much money we've got available.
Do you plan to do a trial with adults at some point as well?
Absolutely.
When do you think the phase 2 would start?
I would say as soon as we have the funding. You know, when we first started this, I had said to Dan Driscoll, you know, that I wanted to start in January 2016. He thought I was overly ambitious. I may be overly ambitious, but that's my hope would be that we could do this as quickly as possible. You know, we've already put out feelers to the FDA about what we need to do for this. We've put out feelers to the contract manufacturers, to Novartis, to everybody involved, just so we're ready to go as soon as we have the financing available.
Will the second stage include younger ages, which I believe you did?
Yes, I did answer that, yes. Mm-hmm.
Has FPWR committed funds for this clinical trial, or is it still contingent on approval by them, which I believe you said is dependent on the, yeah, kind of can't have one without the other. Once the drug is approved, will it be available for adults with PWS too?
I don't see why not. I think it would be available for everybody.
Is the placebo/drug status blinded by parents? Who will report the changes in anxiety, et cetera?
So what we've done for other trials is yes, the parents are blinded, I'm blinded, the study coordinator is blinded, everybody's blinded except for the pharmacist. And we have you, as parents, report the changes that you're seeing. So we have you fill out questionnaires, answer questions, you know, report food diaries, you know, how much your kid ate, how much they left, you know, things like that. And we have something that's called a CGI, a clinical global impression, where we ask you questions like, overall, compared to before you started the study, you know, what have you seen in your child? A minimal improvement, you know, a huge improvement, minimal worsening, you know, huge worsening, that kind of stuff. So we're looking at a bunch of different factors. So you won't know if it's drug or placebo, and that's on purpose because we need to know if the effects of the drug are strong enough to cause these changes.
Okay. Trying to scroll through ones that you've already answered. I know that you stipulated in your slides what you would like to do for phase 2, numbers of children. Based on those numbers, the minimums, et cetera, losing it here. Do you have an idea of how much money you would need and how close you are?
So I estimated that would need $1 million plus to do 50 kids plus 10 to 15 infants. It's expensive to do drug studies. It just is, you know, I mean, and to do multi-center drug studies is even more expensive. And so my estimate for those numbers is over $1 million that we'll need. So far, we've only raised $14,000. We have some great fundraisers who are doing great jobs to try to raise the money. But as somebody said, it's hard when you're doing it, you know, by yourself. With small amounts that you can raise. So right now we're a very, very long way from where we hope to be to get this trial done as soon as possible.
I'm going to merge two questions because they both relate to anxiety. So one is, if appetite's not a big problem but anxiety is, would their child be considered for the study? A correlating question. I understand the phases of PWS as they relate to nutrition, but is it also categorized by anxiety level?
So the answer is that they have to really, to get the effects that that things like the FDA and pharmacology companies will be looking for, we really do need the kids to be in phase 2B or 3. So food may not be a problem as long as you stick to your schedule. But when kids are in phase 2B, that means that the minute you go off your schedule, food becomes a problem. You know, there's lots of food-related questions, lots of anxiety about what's going to happen next, where are we going next, what's going to happen next, when are we going to have our lunch, you know, that kind of thing. That's phase 2B. Phase 2B is characterized by increased anxiety, not just about food, about a lot of things, about almost everything actually, but a lot related to food. There's a lot of food-related questions when the child is not kept on their schedule or in their little bubble of being at home where everything is organized and planned and things like that.
If the study is limited by funding, would a parent be able to sponsor their own child into the study?
No, it doesn't work that way, unfortunately. We cannot guarantee, even if you fundraise like crazy, that your kid will be in the study. The child has to qualify for the study, and we have to be able to do the study, you know, with the amount of kids that we need. So there's no buying your way in, unfortunately. I mean, fortunately, unfortunately. That's, yeah, you can't do that. It's unethical for research, unfortunately.
If you are just doing trials of this on children, will that mean we have to do this all again for adults? Does that mean adults will wait longer?
So I didn't say we're just going to do it on children. We are going to do adults as well. The individuals have to be in phase 2B or 3. We didn't put an age limit on it. So the answer is no, and the studies are actually being done in adults in France as well right now. So they're doing adults and infants.
That segues into this question of, in what countries is the drug already available for treatment of those with PWS?
None. It is not available anywhere for treatment of those with Prader-Willi syndrome. It is available by prescription in Europe for the indication of breastfeeding, not for Prader-Willi syndrome, not for hyperphagia, not for anxiety, breastfeeding, because it's the hormone that's made when you breastfeed. So the way that some of these people that I gave you the quotes from have gotten it is by telling a physician that they are breastfeeding and getting a prescription for it to use. So it is not available in any country right now for use in Prader-Willi syndrome.
Okay. Is there a site that we can keep track of the dollar amount to keep the drive for funding?
Yep, that site that's up there right now, the site for donations, has a little bar on there that you can keep track, and it tells you exactly how much money is there.
Is there any relation or correlation between the size of the 15th chromosome deletion and results of the study?
So not that we know of. Again, our first study was pretty small. The phase 1 study only involves 24 patients, so we're honestly not sure that we'll be able to pull out that data between the different subtypes of Prader-Willi. We will be looking, of course, but I don't know that we'll be able to pull it out from such a small sample size.
Must a young adult be living at home to participate in the study? Would someone at a school, for example Latham, where strict monitoring is possible, be eligible?
I don't see why not. Yeah, I don't see why not.
Okay, this person's child is 21. Would she be able to be part of the study? I think you've already addressed that. She's not sure what her nutritional levels are. Let's see. My husband is always very concerned about long-term side effects when it comes to our son's medications and supplements. Am I correct in thinking that is not a big concern with oxytocin, since it is something that the body already produces?
So the answer is we honestly don't know. It's one of the reasons why the studies need to be done. We don't know If giving oxytocin, when it makes these changes in the brain, are those permanent changes in the brain? Are they temporary changes in the brain? Do you have to give it forever? Can you give it, intermittently? Things like that. We don't know the answer about long-term side effects or even long-term effects of long-term dosing, like with growth hormone. So that's something that remains to be determined.
Other than effectiveness shown in phase 2, what do you think may be other factors that would make this drug of interest to pharma companies?
I think it's really the appetite. I think that's going to be what drives them. For me, I think the anxiety part of it is huge. But the appetite, I think, is what's going to interest pharma companies the most.
The children that you discussed in the presentation, they were all participants for the phase 1 study, ?
No.
Noticed some had been on drugs a couple of years, or are they being prescribed the drug privately?
Yes. And so in Europe, again, for the indication of breastfeeding. So these are people who have been able to, I don't know how to say this, get around the system, maybe is the way to say it. They've been able to get the drug, although it's not specifically indicated for their child. They've been able to obtain it. But it's all in Europe.
What do you do if you get good results from phase 2, but Big Pharma still isn't interested after the phase 2 trial?
I can't imagine that would be possible. But if it was, then some of the parents have talked about potentially working to get investors to start a company to do this themselves.
What if they get good results in France and they make it available to their population? Will that help speed up the process in the U.S.?
I think it would. However, they're in the exact same position we are, in that they still need to really do a good, strong phase 2 long-term trial. That's what they're doing in the adults right now, but they still haven't done kids, and they haven't done any long-term studies in the infants. They were very short-term dosing as well. So I don't know that it's going to happen any sooner in Europe than it would happen in the United States.
What is the likelihood that medical insurance companies will cover oxytocin once approved? Was there difficulty getting growth hormone covered at first?
Right. So I suspect that there, may be a little pushback like there was with growth hormone at first. But we have orphan drug rights for oxytocin, which means that whatever company makes it has exclusivity to produce that drug specifically for the indication of Prader-Willi for the next 7 years. Once it's approved by the FDA specifically for this indication, the insurance companies have to cover it.
Who currently owns the rights to oxytocin?
Novartis, which is a company that's in Switzerland, I believe.
Do you know what will be required of participants for phase 2, meaning travel to location, how long of a stay, a week? Will it be 2 separate trips to the location for the dosing of the oxytocin?
I have no idea because I haven't written the protocol yet. But my suspicion is the way that I want to do it, it would probably be trips once a month or once every couple months to the site for a couple of days each time, maybe a day, I don't know.
This is probably a premature question, but who do we contact if we are interested in having our child participate in the phase 2 trial?
Right now, people are letting me know, and I have a list, but again, people will have to go through pre-screening. So once we have the funding, I'll ask TWSA to put out an announcement with the sites that will be involved, and then they can, with the study coordinator's information, so that people can contact the site closest to them.
Why would I not buy it online and give 8 IU minimum every 3 days if it works so well and no serious side effects, maybe increase to 16 IU if no results are achieved?
One thing, because what you buy online is not truly oxytocin. It says it is, but it's not. It's like anything else that's not regulated by the FDA. You do not know what you're getting, number one. Number two, you are squirting that into your child's brain. And so you don't want to put something in there that you don't know what's in there. I wouldn't, at least. And you don't know the dose. I mean, those doses were for those particular kids. That was 5 kids, and that's all that are on it in the world right now. You know, so we don't know what the right dose is going to be for what, you know, for each kid. You know, maybe for your kid it would be, you know, 4 IUs once every 4 days. You know, we just don't know the right dosing. And like I said, what's online is not the real stuff. So it's, you know, it's to me, at least in my mind, it's very dangerous to consider doing that, because you are putting something into your kid's brain that you don't know what it is.
Who is, this is probably Novartis, but who will provide the oxytocin for your phase 2 study?
Like I said, we're not entirely sure. It's either going to be Novartis or one of these contract manufacturing companies that will make it for us.
Do you know what the study will cost per child?
No idea. Again, it depends on the funding and what we can actually do for each child.
I'm flipping through. I think we've answered most of the questions that have been posed. I'll wait just a couple minutes to see if people want to add a couple more questions before we close out.
I know Dr. Driscoll is also on. If he wants to let Julie know if he has anything he wants to add, I'm sure people would love to hear from him as well.
I will go ahead and unmute his line in case he wants to say anything. So hopefully he's not doing anything that we'll hear that we shouldn't be hearing, like eating his dinner or something.
No, I don't have much to add. I think you did a very good job, Dr. Miller. And I'm anxious to go on it myself.
Okay, I'm not seeing, if children suffer from PWS and NF1, will they be eligible for this study?
I don't see why not. I don't know that we're going to exclude for any other comorbid conditions. It's something we'll have to discuss, Dr. Driscoll and myself, but I wouldn't see why not.
Do you have an estimate of how long phase 3 would take?
My hope is that if phase 2 shows what we hope it will show, that the phase 3 study will be like all the other studies we've designed for this population, where it'll be 6 months placebo-controlled, 6 months everybody gets drug, so a year-long study. Most of the definitive studies from the FDA have to be a year, but they don't have to be a year placebo-controlled. They can be 6 months placebo-controlled, 6 months everybody gets drug, to look for the side effects and the effects of the drug in the whole population.
Since you won't know what to do with your time after all these studies are successfully completed, have you considered looking into gene therapy for Prader-Willi syndrome?
That's Dr. Driscoll's area, not mine. Remember, I'm an endocrinologist. I only do hormones. So I will say that that people who were in the phase 1 study posted some things online on Facebook that they saw, and it really got a lot of other communities very excited about this drug. So over the past several months, I've spoken to several other organizers for family-run groups for other syndromes and other conditions like craniopharyngioma and things like that, acquired sort of Prader-Willi syndrome conditions, and they're super excited to try it in their populations as well. So that's kind of neat to think that it not only could help people with Prader-Willi, but could help other syndromes as well, and other people who are suffering from similar symptoms, even if they don't have Prader-Willi.
Exactly. It makes me think back to when growth hormone, which for most people who have a child under 15 is the norm, but didn't used to be. It
Right.
was, my niece was the youngest patient Dr. Driscoll started, and at that point she was almost 2. So it's pretty exciting that someday we might be able to look back on this and say we were part of a life-changing experience for our children. Well, several hundred people, including people from 30 to 40 countries, have signed up for this webinar and have either listened to it tonight or will be receiving the recording tomorrow. And I think that's a real testament to the interest in our community, to the work that Drs. Driscoll and Miller are doing in this area. And we thank you. Those two words just don't even mean enough for the amount of time that you give to work and volunteer for this syndrome. So with that, I think we will close the evening, and I thank everyone that participated. Good night.
Thank you so much, Julie. Thank you all for participating and listening. Bye.
Bye-bye.